Guys, this is Mobeen. We are talking about the respiratory system. Today is the introduction to the restrictive lung diseases. Definition of the restrictive lung disease is simple. It is any condition in which there is not enough volume of the lungs left to allow the air to go in. So there is a restriction to the amount of air going in. The types of restrictive lung diseases are three primary types, and then under each type we have separate definitions. The definition and the diseases that we will primarily cover in this series are going to be the lung parenchymal diseases. So let's first look at the types of the restrictive lung diseases. So types are extrapulmonary, pulmonary parenchymal, and neuromuscular. So three primary categories of the disease. What are these? Extrapulmonary, for example, obesity, simplest. Patient is so obese that there is enough weight on the chest that patient is not able to move the chest properly, and so lungs are not expanded correctly and there is not enough air that goes in. That is obesity. Similarly, scoliosis, which is the sidewise movement or sidewise scoliosis, which is the angulation of the spinal cord, and that causes restriction in the pulmonary or chest movement as well. On the neuromuscular, there could be, for example, myasthenia gravis. There can be problem with the diaphragm. There can be polio, and so on. So neuromuscular, myasthenia gravis, diaphragmatic failure, or poliomyelitis, and so on. So these are the ones where the muscles are not working. And then the parenchymal diseases can be idiopathic. Idiopathic, we do not know what is happening. These can be autoimmune, granulomatous diseases, for example, Wegener's granulomatosis or sarcoidosis, and similarly occupational diseases where we could have pneumoconiosis or the minerals like silica, asbestos, coal, and so on. And of course that would also mean other irritants, for example smoke, dust, or other such allergens that are chronically irritating the lungs. With that, then that means chronic infections, for example. So if I put here chronic infections, for example tuberculosis, and so on. The lecture series that we'll do, in that we will actually be talking about the parenchymal diseases or the diseases of the lung tissue itself. We are not going to talk about extrapulmonary here, and we are not going to talk about the neuromuscular problems here. Okay, so with this now let's start. The definition of the parenchymal interstitial disease is usually chronic, sometimes it resolves. So that is why we say the word usually. Usually chronic progressive disease of the fibrosing disease of the interstitium of the lungs. Now, what is the interstitium? What is the definition of the interstitium? So, let's see here. This is an alveolus, this is a capillary. So, this is one artery or branch of the artery, this is an alveolus. Starting from here all the way till here, what do we have? We have epithelial cells. So, these blue cells are epithelial cells. Then outside here we may have some collagen fibers, right? We may have some elastic fibers, so collagen and elastic fibers. We may have some occasional mast cells sitting here, some other mononuclear cells sitting here. We have macrophage sitting inside the alveolus in the free alveolar space, and then we have the endothelial cells here in the capillary or the blood vessel. Of course, that also means we have basement membranes that are present both on the endothelial side and on the epithelial side. So, this is the basement membrane here. This is the basement membrane here. Now, the interstitium in all of this, just remove the macrophage and all the rest is the interstitium. That is also the respiratory interface, right? So, that will be from the alveolus to the blood vessel, that will be epithelial cells, both type 1 and type 2 pneumocytes. Then the elastic fibers, collagen fibers, some mast cells sitting here, some other monocytes sitting here, some fibroblasts sitting here, very few in number, some smooth muscle cells, very few in number or not at all, and then finally the basement membrane of the endothelium and the endothelium itself. This is the composition of the respiratory interstitium or the respiratory membrane. So, now looking at the pathogenesis, how we'll use this diagram is this way. If I make this diagram into half, we'll use this as normal, we'll use this as an active area of inflammation and damage because of all of these problems, and we'll use this diagram as the final result of the pathogenesis. Okay, so normal healthy system, you know that we have type 1 pneumocytes, we have type 2 pneumocytes. Type 2 pneumocytes are responsible to make surfactant, plus they are responsible to make type 1 pneumocytes. It is their job. Why am I talking about that over here? When there is damage to the alveolar epithelium, type 2 pneumocytes will become hypertrophied. Why? So that they can make more type 1 pneumocytes again. Keep this in mind. One. Second, now let's start. What happens is, let's say the patient is either working in a occupationally hazardous area, or he's a smoker, or he has gotten tuberculosis and the disease is recurring. So, let's look at any situation where there is a recurrent problem which causes injury and then repair occurs. Remember, this can be acute as well. For example, adult respiratory distress syndrome, if I put that over here, ARDS, or even the RDS, the infant's respiratory distress syndrome. These are also restrictive lung diseases, but they can be resolved as the problem goes away. Here we need something that would continuously cause the problem. So, let's say the person is a smoker. So, the smoke comes in, it causes irritation to what? It causes irritation to the macrophages, and it irritates the epithelium. First, we are starting, right? Now, when the epithelium is irritated, what happens to the epithelium? Number one, is apoptosis of epithelium. What does that mean? That will mean some epithelial cells would start getting destroyed. Right? So some epithelial cells have become destroyed, that area has become damaged, tissue factors have become exposed, and the clotting and inflammation would start. So that is one possibility. When the irritant has irritated the macrophage is going to release interleukin 8, IL-8 and leukotriene B4. Remember, this B and 8 look almost the same. So keep this in mind. Both of them are going to cause chemotaxis of the neutrophils. So with this, when this IL-8 is released and leukotriene B4 is released, that causes neutrophils to do the diapedesis and come in here. So here is a neutrophil that has appeared. What will this neutrophil do? When it would come in here, this neutrophil will cause cytokine releases, plus it would cause reactive oxygen species to be released. It will release proteinases or proteases. It would release tumor growth factor beta. So that would start amplifying the inflammatory process. Meanwhile, macrophage would also release the fibroblast growth factor. These are just the inflammatory factors, right? So there's nothing magical here. The transforming growth factor beta, which is really important, and nowadays the latest treatments are focused on forming drugs that can block the TGF beta's effect. It is very promising, and it is actually more promising than steroids. So keep this one in mind, TGF beta. If you forget everything, forget it. Don't forget TGF beta, because that has pharmacological and promising outcomes. With that, of course, tumor necrosis factor will be there, platelet derived growth factor will be there. So all those factors will cause what? They would cause further platelet activation, they would cause clot formation, and these would cause the inflammation to start. In addition to that, what will happen is this tumor growth factor beta and the tumor growth factor beta coming from here, these will work on the little innocent fibroblasts that are sitting here. They are quiet, they are not doing anything. But as soon as they are acted on by these chemical substances, they will become active, they'll start proliferating, and what will they do once they become active and proliferated? They are going to start making a lots and lots of elastic fibers and collagen. So can I now say that this area has started becoming thick because of the inflammatory process? So I would go here and I'll start creating thickness in this respiratory membrane. So not only epithelium is getting damaged, but now there is, because of the inflammation, there is more connective tissue and ground substance, and the reparative scar tissue is being formed. Okay. Another thing that would happen is that these chemical substances and the damage to the epithelium will cause something that we say EMT, epithelial mesenchymal transformation. Excuse me. Epithelial mesenchymal transformation. What does that mean? That means these epithelial cells that are sitting here, these cells will become mesenchymal in origin, they will become ancient cells, and they would start migrating underneath, and as they come down here, as they migrate over here, they will start becoming smooth muscle cells. So myocytes and fibrocytes. So they'll start becoming smooth muscle cells. So now what are we getting? We are getting a lots of fibroblasts, right? So these were these cells. Now we are getting a lots of smooth muscle cells. All of that, what is the damage that is happening to the patient? That is causing the thickening of this respiratory interface that would prevent or reduce the gaseous exchange, which will mean that the oxygen will be staying in the alveolus and not go here. That would be hypoxia, and which will mean carbon dioxide will not go out. That would mean increased pressure of the carbon dioxide in the blood, causing respiratory alkalosis. This also means that patient will have a problem with the oxygenation. So patient would now exert, he would try to breathe because the body's needs are not met. So patient will become aware of the breathlessness and would exert, and that would be dyspnea. So patient would become dyspneic and hypoxic. Now with this all, this epithelium that has become damaged and apoptotic, and then proliferation of pneumocyte 2 will occur. So the relative concentration of the pneumocyte 2 is more. And why is that interesting? For a couple of things. Number one, pneumocyte 2 will secrete, let's secrete it this way. Actually the blood vessel is here, so let's secrete something here that is called macrophage chemotactic protein. Macrophage chemotactic protein. What is the function of that protein? It is going to ask more macrophages to come in, and more macrophage mean more inflammation and more problems. So this is an amplification done by the epithelium. In the old times it was thought that epithelium would simply it's a victim of the injury. But now it is clear that epithelium is not only a victim of the injury, it is actually participant in further damage by doing such things. So number one, it does this. Second thing, that this thing, the pneumocyte type 2, start releasing plasminogen activator inhibitor type 1 and 2. And what is the significance of that? Of course, as the name says, plasminogen activation inhibitor means plasmin work or plasmin presence will reduce. And what is the function of the plasmin? Reduce the clot, break down the fibrin. So when the clot and fibrin are not going to be reduced and broken down, then this whole area would have more and more scar tissue, and that will mean more scar tissue. So much scarring will cause what? So these are the cellular events. Now if we go back here, what is the outcome? The outcome is that the lungs have become restricted. Again, we were talking about parenchymal restriction. So lungs are now stuck within themselves, and imagine if this is an alveolus, the scar tissue around the alveolus is acting as a thick leather ball, and it has grabbed the alveolus, and alveolus cannot expand. So compliance or the expansibility is reduced. Elasticity is increased. Don't forget this. Elasticity is increased. Why? Because there is a lots of scar tissue. So if you try to fill this, the scar tissue is going to press in, and it is going to be easier to exhale fast. So compliance reduced, elasticity increased. What will that do? What would happen to the FEV1 and FVC? First of all lung capacities and volumes will reduce. You ask the patient to breathe deep. So let's say if the normal person can breathe in 4 to 5 liters, this patient is going to be able to breathe in 3 liters. So that is one. All volumes and capacities will reduce because of the restriction. Number two, FEV1. What do you think? When you ask a patient to take a deep breath and then exhale fast, will the patient be able to exhale fast? So let's see if I become the patient. Yes. Why? Because the lung is elastic, very elastic. So it would very quickly expel the air out. So what will happen is that FEV1, so here if I type FEV1 and FVC, they both are reduced in general. They both, all lungs and capacities, all volumes and capacities are reduced. However, they are all reduced in proportion, and FeV1 actually may have increased. This is the forced expiratory volume in the first second, and so FeV1 over FVC ratio is actually greater than 80%. Remember, in the normal it is about 80%, and in the obstructive lung diseases it is lesser than 70%, and in here it is normal or above normal. So FeV1 divided by FVC, or that ratio, will not tell you much. It is the overall reduction in the volumes and capacities that is important. So clinically, how do you see this? The patient is going to be having dry hacking cough, dyspnea, hypoxia, respiratory alkalosis. There will be crackles, late inspiratory crackles will be there. Volumes, we've talked about this, Then the chest x-ray, what would you see? The chest x-ray overall, the volume will be reduced. And it is interesting that the lower lobes will normally show more involvement. Why? What do you think? What is the reason? The reason is this, guys, don't forget this. As the lung airways start dividing, and as you go farther and remote, the distance between the blood vessel and the alveolus is almost finished, and the basement membranes of the two are almost fused with each other, and there is nothing else here. This basement membrane is fused with this, and they are kind of together. So this thin and delicate area is very easy to damage. That is why remote parts and the peripheral parts, they get scarred first, and they get damaged first, and they get atelectazed, or they collapse first, which then form cysts, and you would see the honeycombing on the chest x-ray. Of course, you would see reticulonodular appearance in the lower parts as well. Mediastinum will become dilated. Now, what do you think will happen to the heart? Heart is sitting in there and trying to pump blood. Right heart is trying to pump blood in the lungs, and the lungs are all scarred and restricted, and they do not have enough volume to allow the blood to come in. Heart will become hypertrophied. Which heart? Right heart hypertrophy is called cor pulmonale. So cor pulmonale would develop in the chronic cases. When the cor pulmonale would develop, then you would see the edema, right? And then the patient can die of the respiratory failure or the right heart failure. It is a devastating disease. For example, in the idiopathic, so this is the pulmonary fibrosis. If you put an I over there for idiopathic pulmonary fibrosis, normally from diagnosis there are 3 more years for the patient to live, as bad as the cancers. So that is the situation in the x-rays and with the heart. Treatment, of course, anti-inflammatories are given because it seems like this is the inflammatory process, repeated inflammation. However, it is not seen, at least in the idiopathic pulmonary fibrosis, these have not been very effective, although they slow down the process of the damage. Nowadays, major treatment is coming in the form of the TGF-beta blockers that would block the TGF-beta, and TGF-beta is not, it's a pleiotropic molecule, so not only it causes the activation of the fibroblast, but it also causes proliferation of many cells over here. So it is supposed to be a main culprit here. So that these drugs are given. Oxygen is given to improve the quality of breathing, and then it is possible that the patient would need lung transplants. Cool. Thank you.